Well, hello, we better get going. To inspire you to pay attention in the next lecture, I'll tell you that many of you look like the fellow criminals I was with at my education meetings, where he is one of the lecturers. The people there had gray hair and they were solo practitioners. So this is a good fellow to pay attention to. Many good things come from being charged with 3 felonies, and Dr. Achar is among the best of those things that I encountered. Suraj Achar, MD. He teaches the Physician Assessment and Clinical Education PACE program to physicians from around the country at the University of California, San Diego, as well as the American Academy of Family Physicians Scientific Assemblies. He focuses on law and medicine. Achar completed his residency and fellowship training at the University of California, San Diego School of Medicine. He earned his medical degree from the State University of New York at Buffalo School of Medicine and is board certified in family medicine and sports medicine. San Diego Medicine Magazine, San Diego Magazine, Physicians of Exceptional Excellence, has repeatedly named Achar a top doctor in its annual survey performed in collaboration with the San Diego County Medical Society. In his spare time, Achar enjoys running marathons with his son. Dr. Achar.
Thank you so much. I'm so proud to be here. It's a wonderful opportunity. So let's go ahead and get started. Can you hear me with this? Or maybe I'll even use the mics if I move. Got that. Kind of interesting mic here. But I'm not actually sure how to use this. Put it in there and see what happens. All right. Does this work? You may have to turn the slides for me. I don't think this slide thing turns. I'm just pushing the button here. Okay. Okay. Huh. All right, so here's some of the topics we're going to talk about. You know, I've come from San Diego and I've really enjoyed Utah. In fact, one of my favorite places is Zion, and visiting the parks and also visiting the mountains up here. It's kind of crazy. I think the best skiing, the best hiking, some of the best outdoor activities all here in Utah. And I feel so glad to be here again. And I get to run, because of the race, I get to run a little bit on Saturday, which should be really fun. So I'm looking forward to that. Today we're going to talk about part of this. There's been a lot of stuff going on recently. The U.S. Senate and Congress has passed 11 new laws on controlled substances since March, and they have 8 new ones about to pass, I think, in the next week or two. So a lot of stuff has happened. The CDC has come up with some new guidelines that we're going to discuss in the second half of this presentation. We're going to go ahead and get started in Southeast Asia. And actually, a lot of the story starts in Southeast Asia. Actually, so the opium epidemic maybe started about a century and a half ago in Southeast Asia. And with that, an international treaty was signed, including a treaty with the United States and Teddy Roosevelt, to try to reduce the trafficking of opium products. With that also was designed a synthetic drug called heroin, which was initially designed to help people get off of opium as an addiction, which is kind of interesting. Now we go back, we flash forward about 100 years later to Southeast Asia again. We're sending our best and brightest soldiers, young men, to Vietnam. And many of them are getting involved with opium again. So the opium use of our soldiers probably, and opioid products, maybe around 20%. And when they're coming back to the United States with this addiction, it was a national crisis. Now, fortunately, when they came back to their temples and their families and their churches and synagogues, many of them stopped using. Work and home life helped them, and so only 5% continue this addiction of heroin and other drugs, opium products. Now, this was still a big crisis. 1 in 20 of our soldiers, best and brightest young men, coming back from Vietnam, addicted to opioid products. With that, the government became involved, the Nixon administration, the United States Senate, United States Congress, and they passed a series of laws, including the Controlled Substance Act. Out of this series of laws was the birth of the DEA, and a bunch of the rubric for how we take care of patients with controlled medications was all started right around this time. And you can see a bunch of drugs are in this list, but it's interesting, one of the drugs that's really strange, but it's on this list and still remains on this list is marijuana. And so doctors get a little confused about this because you can see this map here. It's a map of all the different state laws. So we're going to talk about hospital rules, we're going to talk about state laws, and we're going to talk about federal laws and how we have to intersect with all these different agencies and regulatory bodies that that help us decide how to take care of our patients. Marijuana is one of those where it's a bit tricky here. So in Denver, there's more there's more marijuana dispensaries than Starbucks and McDonald's combined. There's over 250 in the city of Denver alone. And with this, both state of Washington and state of Colorado have seen a big uptick in the use of marijuana amongst our kids. So about 50% increase in children using marijuana, even though the laws of Washington and Colorado never included children under the age of 18. Now, it's on the list, and it stays on the list for all of us. So doctors get a little confused. If you're a physician in Colorado, you can go to these marijuana dispensaries and you can get marijuana for yourself, but you cannot prescribe marijuana. And so doctors get a little confused because you're regulated by the DEA, and your DEA license prohibits prescribing this except in one case, and that's research. So if you're doing an Institutional Review Board approved human subject study by your hospital, you can study the use of marijuana, medical marijuana, but you cannot prescribe it for your patients. And this is true in California, where they had the California Compassionate Use Act. So it's a bit confusing for physicians. There is one form of THC that you can prescribe, Marinol, but it's very different than the plant form, which is probably 250 different chemicals. Marinol is one different chemical. And so that form you can prescribe, but the others you cannot. So a bunch of stuff's on this list, including Hippocrates. Now, Hippocrates, many of you guys will wonder, it kind of sounds different. It doesn't sound like a drug that you know of. Some of you guys have it on your cell phone, or at work, you may have it on your computers. It's a program by a Silicon Valley-based firm that devised technology early in the days of the Palm Pilot, when we first started using smart technologies in our pocket. The Palm Pilot they developed a form of a drug database that physicians could just look at. Now it's been mostly replaced by electronic medical prescribing. However, you can still use this, and it's interesting, the name. When you see that name, you think of Hippocrates, right? So every one of us, when we graduated from medical school, we raised our right hand and we gave some oath that's based on some of the values of Hippocrates, including primum non nocere, do no harm. And so it's interesting that Hippocrates is on the list, and I'm going to talk about this tomorrow when I talk about anatomy of medical errors and why prescribing is such a big issue. Okay, so fortunately, with the first war on anything, the war on drugs of the Nixon administration, we have caused a decrease in the use of street drugs. Until recently, this decrease has been pretty dramatic amongst our children, and this is wonderful. And little did we know that there was another epidemic brewing underneath all of this. And this epidemic we're going to talk about today is prescription medications. And it's interesting, you see this number 20% again. So about 50 million Americans admit to currently or in the past abusing prescription-controlled medications. Most of them are opioids. So it's a big issue, and it's been published. This data is published by the Office of the White House and the National Drug Control Policy, the National Institute of Drug Abuse, which is a big branch of the NIH, and SAMHSA, which is the Substance Abuse and Mental Health Division of the U.S. Department of Health and Human Services. So it's a big number. And 20% kind of comes back in this story a lot. We'll talk about the 20% number over and over because you see that. This is a story that touches all of us. If it's 20%, you all have friends, families, personal experiences with addiction. And this is something that is so important. When it happens to your family or your children, it's overwhelming. Now, as we talked about, lots of stuff is happening. It's almost lightsaber speed. So I showed you the Doc Vader video up there, and I think this is very important. The San Diego County Medical Society is very concerned about patient satisfaction scores, linking that to doctor pay. And part of the reason is we have this epidemic of over-prescribing of opioids and controlled medications in America, leading to injury and death. And the problem with patient satisfaction scores, you may have 1,000 patients and 30 will send in the scores, and the 30 that send in the scores may not be the happiest campers that you have. And so unfortunately, this has led maybe to part of the problem. So that's why I showed you the Doc Vader video to show it. Now, Congress and the Senate is actively working on this issue right now, and we're going to talk a little bit about how this affects Ogden, because this is an important issue right here at home. So there's been 11 laws passed since March, and there's 8 laws on the docket for the Senate and the Congress. And most of these laws in the Controlled Substance Act changes are all unanimous, or pretty close to unanimous. So we'll hear more about this. Now, some of you guys may know Eminem. So one of these is false, and I'm going to ask you just to raise your hand to tell me which is false. His song, Lose Yourself, in 2004 was the longest #1 in music history. And the other one is Mathis admits to an addiction with methamphetamine, hydrocodone, acetaminophen, zolpidem, and methadone. Is A, raise your hand if you think A is false. A is actually correct. This was Best Original Song Academy Awards, and at the time was the longest #1 song in music history. Mathis, like many of our famous movie stars and actors and actresses, had an addiction, was admitted to rehab, but all the drugs that he was addicted to were prescribed to him. So not methamphetamine. They were hydrocodone, acetaminophen or Vicodin, Ambien, and methadone, all prescribed to him by doctors. Now, we have this little video, and this happened just last few days ago, and I wonder if we could show it now. This is Macklemore, another big Grammy Award-winning artist, with Obama talking about this. Do you have it? Can we put it up? Got it. And they're discussing this together in the White House, and there's been just a lot of news on this since all these laws have been passing. You know what I'm going to do is I'm just going to go on to the next one while you're pulling that up.
Hi, everybody. I've got a special guest with me this week, Macklemore. Now, for those of you who don't share the same love for hip-hop that I do, he's a Grammy-winning artist, but he is also an advocate who's giving voice to a disease that we too often just whisper about. The disease of addiction.
Hey everybody, I'm here with President Obama because I take this personally. I abused prescription drugs and I battled addiction. If I hadn't gotten the help that I needed when I needed it, I definitely would not be here today. And I want to help others facing the same challenges that I did.
Now, drug overdoses now take more lives every year than traffic accidents. Deaths from opioid overdoses have tripled since 2000. A lot of time, they're from legal drugs prescribed by a doctor. So addiction doesn't always start in some dark alley. it often starts in a medicine cabinet. In fact, a new study released this month found that 44% of Americans know someone who has been addicted to prescription painkillers.
I didn't just know someone, I lost someone. My friend Kevin overdosed on painkillers when he was just 21 years old. Addiction is like any other disease. It doesn't discriminate. It doesn't care what color you are, whether you're a guy or a girl, rich or poor, whether you live in an inner city, a suburb, or rural America. This doesn't just happen to other people's kids or in some other neighborhood. It can happen to any of us.
That's why just talking about this crisis isn't enough. We need to get treatment to more people who need it. My administration is working with communities to reduce overdose deaths, including with medication. We're working with law enforcement to help people get into treatment instead of jail. And under Obamacare, health plans in the marketplace have to include coverage for treatment.
I know recovery isn't easy or quick, but along with the 12-step program, treatment has saved my life, and recovery works. We need our leaders in Washington to fund it and for people to know how to find it.
We all need to do more to make that happen. I've asked Congress to expand access to recovery services and to give first responders the tools they need to treat overdoses before it's too late. This week, the House passed several bills about opioids, which is great, but unless they also make investments in more treatment, it won't get Americans the help that they need. On top of funding, doctors also need more training about the power of pain medication they prescribe and the risks that those pain medications carry. Another way our country can help those suffering in private is to make this conversation public.
When you're going through it, it's hard to imagine there could be anything worse than addiction. But shame and the stigma associated with the disease keeps too many people from seeking the help that they actually need. Addiction isn't a personal choice or a personal failing, and sometimes it takes more than a strong will to get better. It takes a strong community and accessible resources.
The good news is there's hope. When we talk about opioid abuse as the public health problem that it is, more people will seek the help that they need. More people will find the strength to recover, just like Macklemore and millions of Americans have. We'll see fewer preventable deaths and fewer broken families.
We have to tell people who need help that it's okay to ask for it. We've got to make sure they know where to get it.
We all have a role to play. Even if we haven't fought this battle in our own lives, there's a good chance we know someone who has or who is.
President Obama and I just had a powerful conversation here at the White House about opioid abuse and what we can do about it. You can catch it this summer on MTV, and to find treatment in your area, call 1-800-662-HELP.
Thanks, everybody. Thanks, Macklemore.
Thank you.
And have a great weekend.
Shop Woodhouse.com for all your vehicle needs.
What's going on? What?
Sorry, I had to bounce back. It's hard to embed that video. Let me see if I can scoot forward then to the server. So as President Obama talked about, the overdose rate has really gone up a lot, and about 2000, 2001, you can see a little spike here, and recently it's leveled off, and that corresponds to a time when JCAHO made a decision with the support and advice and financial backing of Purdue Pharma to create the fifth vital sign. This entire document was partly written by Purdue Pharma and was shipped to the JCO and was passed around. And with that, we see an increased rate of prescription overdose deaths versus overdose deaths from other causes such as cocaine and heroin. Now, let's see, do we have, so this talks about the drug overdose rates in Colorado, how this compares to all other deaths, including motor vehicle accidents, which you can see down here is much lower. Now, this affects all ages. Obviously, the middle age group is the highest risk, but it's interesting when you see this age down here at age 65 and plus, you think that's a relatively small number. That's about 300,000 Americans over 65 who are addicted to prescription opioids. So it's still a big problem, even though it pales to the 7 or 8 million here. It's still a big number way out in these full extremes of age. Now, with kids, they get these drugs in different ways. It's kind of interesting. One thing I learned about is the trail mix. I have a 16-year-old son, and I heard about this from other kids too, this trail mix thing that kids will have, where they gather whatever pills they can from grandma, who stores them for a decade in the closet or whatever, in the medicine cabinet, and they go to the parties and they throw it all together in a big basin and just pick out whatever. They don't even know what they're taking. So half of the time they're getting these drugs from their friends without even knowing what's really the risks. Now, marketing is a big part of this all too. It's not just the fifth vital sign. With that, there was a big push by a couple companies, including Indo Pharmaceuticals and Purdue Pharma, makers of very expensive opioid products, Oromorph and OxyContin. Marketing increased sales, which is kind of a unique thing to America. We have this direct marketing to doctors and now to patients, and with that, increased death rates. Now, if you ask patients, they would rather choose these drugs. Prescription drugs are far and away ahead of heroin, but they don't always use these drugs, and the reason is they run out. So if you've been prescribed a prescription opioid, your chance of heroin abuse in your life goes up by 40-fold. By 40-fold. And part of this problem is heroin is cheap and readily available. So if your doctor decides to stop prescribing opioids, if you have an addiction and you have no treatment options and you're not want treatment options, this is a cheap way to go. Now the problem is some of the heroin products are very highly potent products, and they're often the worst ones. Recently, we've seen a rash of deaths in Indiana. They actually mix them with fentanyl, one of the most potent opioids that we have. So deaths were astounding. And when this happens in your family, heroin use affects family members. It's devastating for the family. Now, we talked a little bit about the heroin abuse, and as you can see, heroin abuse is going up. And the reason it's going up is we're doing a better job educating doctors, I think, around the country. New laws have been enacted in multiple states, not just federal laws. State laws in the state of Washington really changed prescribing and dropped prescribing by 50%. State laws in Florida, big-time changes in prescribing. And with that, heroin increased. We'll see the data on the next slide. As you see, as we're tapering off opioids around 2011, heroin has started to come up. Now, we're not quite out of the woods yet, and this is an underrepresented number. One of my patients recently died from a combination of opioids and benzodiazepines. The newest CDC guidelines said we just shouldn't do it. The evidence is pretty clear. We shouldn't give the same patient a benzodiazepine and an opioid at the same time. I'm going to share you stories why that is true. But this is unfortunately done, and I was doing this as well, and I recently had one patient die from this. And I don't think the death report actually fully represented this, so I think we're under, this number is below the number that it actually is. Now, here in Ogden, I learned from a presenter yesterday about this problem. Utah has a kind of a special issue with a lot of the population here following the tenets of keeping their body as their temple and staying away from alcohol and other drugs potentially. Prescription opioids is allowed. And maybe this is one of the reasons why Utah's 5th in the nation in opioids, and for some reason reason is not following the trend nationwide, where we're seeing a drop in opioid prescribing. Utah hasn't really seen that. Here in Ogden and Weber State also, we can see this is a big problem. And this, one of the reasons I showed the Obama tape there is the 8 laws that are left to be passed, hopefully to be passed, would include funding for treatment. And so I think that's a big issue. We need some place for our children, our family members, our patients to go if they have this addiction in order to get treatment, and we need some funding for that. And this is true here, and the Health and Human Services person at Weber here talks about it. Wendy Davis talks about it in a news report recently. Interesting about Utah, the #1 cause of opioid overdose deaths in Utah is OxyContin, 52%, which is much higher than the rest of the country. So OxyContin especially is prevalent over here. So how do heroin users start? We talked about this already. 4 to 5 start with a prescription by a doctor for a valid indication for an opioid. So what this basically means, and one thing is we're trying to talk about now, is trying to keep our patients opioid naive. What we want now is to try to keep people opioid naive their entire life. So if there's an opportunity to, the first guideline from the CDC says do not prescribe opioids. That's the very first thing. It says don't prescribe it. The second thing says if you have to prescribe any medicine, use a non-opioid. But if you can't, don't use medicines at all. And I think if we can do this, we can save a lot of lives, and we can save a lot of tragedies in families. And so this is our task, our duty. It does say also CDC guidelines, I'll talk about this tomorrow my part 2, it says if we do prescribe very short term, like 3 days. They talk about 3 days. And then I talk about some other things which I'll share with you later. Now, fortunately, we've seen a downtick now with this growing awareness nationwide. We've seen a downtick in the use of opioid drugs in our kids. In 2004, 11% of our high school seniors and like 8% of our 8th graders in this country admitted to using Vicodin. Now in 2014, this number has come down to 4.8%. Interesting, none of these kids who were using Vicodin were prescribed Vicodin in the monitoring this survey. It was all, they got it from medicine cabinets that are floating around. We don't really have a great system for getting back drugs. We have a great system for giving drugs, but not a great system for getting back drugs. And same thing for OxyContin. It used to be 4 to 5%, and it's now in the 1 to 2% range, so it's much better. Now, California was kind of take the lead in this. I think in 1939 they started a monitoring program and converted that in 1998 to a monitoring program that included all of the schedules through Schedule 4. And what they found is kind of McDonald's numbers. So if you look at this, 100 doses per adult, so 2.7 billion doses were prescribed by California physicians in 2011. If you spread it evenly to every man, woman, and child, every baby in California, it'd be 100 tablets per man, woman, and child in 2011 in California. And California was not leading the country in prescribing at the time. So this is a huge number when we think about the ramifications around the country. This is a mom with her daughter whose son had passed away. There was about 11 of them who gathered around the State House asking the California State Legislature to do something. The state legislature says, well, what are we supposed to do about this? So they asked the medical board to comb the database that we use to monitor physicians to look for the highest prescribers. Medical board has said, no, we won't do that, but the pressure is on. The pressure is on. Now, one of these is not true, and it's interesting. When I first learned how to use these audience response things, I was at Pri-Med in Anaheim, which I thought was kind of cool. I've used them in American Academy, Family Physicians, etc., but I don't really have them access for here, so we're just going to do some of these questions. Just raise your hand. Who thinks that, or just blurt it out. What's the right answer? Which is not true on this list? D. D is exactly right. And I'm going to show you why D is amazing. So laws actually make changes. So Florida was really a hotbed in prescribing, and still is to some extent until like 2010. And then the state Senate got together and said, look, we're #1 in the country, and this is not a thing we want to be proud of being #1 in. So let's find a way to reduce this. And they set aside laws to reduce prescribing, and pain clinics made it a little bit more harder, registration, follow-up, and oxycodone prescribing dropped by 1/4. and oxycodone overdoses dropped by 50%. 1/4 drop in prescribing, 50% reduction in overdoses. Pretty amazing. This was overnight, like within a year. Now, who are the vulnerable populations? When we come to speak at conferences, oftentimes speakers are asked, talk about the vulnerable populations. And in general, they're often the underprivileged, folks who don't have access to health care. The reverse is actually true here. It's actually interesting. The more access to health care, the worse you are. If you're famous and you're loved, the worse you are. So, I mean, I don't think there's too many people besides Michael Jackson and maybe Prince who get propofol at home. I mean, it's just really crazy when you think about it. And you know, as Michael Jackson's doctor, his main task was to keep Michael Jackson alive. He was his only patient. His only patient. So, it's interesting, when you think about patients, angry patients, patients that are demanding for a specific drug are at higher risk for overdose. So we have to, and that's why the patient satisfaction problem is an issue, and we have to nationwide tackle this. Doctors have to kind of come to grips and talk about this together so we understand that we can't let patient satisfaction be everything and change our prescribing habits. So Heath Ledger, I think some of you may remember Heath Ledger. So he was the best actor of The Dark Knight. So The Dark Knight was a 24-hour job for him. It was an obsession. He worked so hard on that project. And he had another project to go, but he came back to his New York apartment after The Dark Knight filming, and he wanted to rest. And he was like, he had gone off of all of his prescriptions, including benzos and a small amount of opioids, to make his movie. And he came home and he took his prescribed medications, and his girlfriend looked at him and she thought, oh, he looks so sad. So she gave him a little bit of her Xanax too, to try to cheer him up a little bit. So he took his prescribed benzos and a little bit of an opioid, not too much. She gave him a little bit of Xanax and she went to get pizza and she came back and he was dead. Now, why did he die? Well, it turns out this is an interesting conundrum that we have, and this is why the CDC says we've got to go low. If you're going to use opioids, stay less than 50 milligrams equivalent of morphine a day. Stay under 2 tablets of Norco or 3 max per day. Never go over there. And the reason is when we can develop tolerance to a large amount, but tolerance doesn't last forever. And so I give this lecture to all the Kaiser Permanente doctors in Southern California, 5,000. And it was a tour of all their facilities, so for 5,000 doctors. And I had one doctor come up to me and she said, oh my gosh, I have a patient, he's on 1,000 milligrams equivalent of morphine a day, and I sent him to pain, and they say, well, he's being compliant, he's following his appointments, he's not missing in, he's doing his testing, he's not having any side effects, continue it. And I said, oh my gosh, that's crazy. Go, who's your pain doctor? And she said, he's over there. So I said, go bring him. So we brought him. So the pain doctor, the pain anesthesia doctor, and the family doctor came over to me and I said, well, I've always wanted to go to Antarctica. You know, it's a dream of mine to go to Antarctica and kind of hang out with the penguins and go walk out there. And I was thinking, well, what if your patient actually came with me to Antarctica? But you know, sometimes in travel, things get mixed up. So we're getting our boat in Patagonia and Argentina, get on the boat, and the luggage doesn't make it for your patient. So we cross in the boat, and of course, this is not a real huge cruise boat with like a ICU and medicine cabinets. So your patient doesn't have her medicines. So what happens? She withdraws. Does she die? No. She manages it, but not a happy camper. And so we get back home, and she never gets her luggage. It's just mixed up. She comes back to her appointment not knowing any better, and she speaks to the doctor, and the doctor doesn't know anything about what happened with her medicine lost for 3 weeks. She's been out for medicines for 3 weeks. Represcribes. She takes it just like she's always taken it, willing in a way following the directions, and dies within a few days. And the reason is her tolerance is gone. So we just can't be anymore at that high level. And many states have come to realize this and have started to say, we just got to drop this. One last group, or a couple last groups that are really at high risk is our soldiers. So my good buddy was the head medical doctor. He took over the head medical doctor of the Wounded Warrior Project in Camp Pendleton. And he had a patient come the first day. And the patient was on a high dose of opioids for an injury that happened 10 years ago. But the injury was better. And he looked at him and said, well, your injury's healed now, sir. Soldier, you're ready. We're going to titrate you off your medications. You don't need this anymore. I'm going to reduce it by 10% per week. In a couple months, you're off. And the soldier said, no, doctor, I'm an injured soldier. I deserve this. I fought for my country. You can't do this. I'm a wounded warrior. And he said, it's not good for you. You're done. Your injury's better. I'm the doctor. I'm not going to give this anymore to you. We're going to go down 10% until you're done. And so he went back to his barracks and he talked to his commanding officer who called. Fortunately, my friends outranked him. So he said, nope, he's going to get titrate down 10% per week until he's off. Okay, next week he got a call from the office of the local congressman saying, how come you're not taking care of our wounded warriors? How can you not do this? And so then he called me and said, Achar, what am I supposed to do with this? And I got a call from the congressman about this. And it's so sad. When you look at the data, it's pretty amazing. You'll see that the soldiers who have PTSD and who have addiction problems, they are getting, 35% of them are getting opioids, which is huge numbers, and these are high risk. Some of you guys may have seen this on CNN just the other day. Ray Lucas, he's a third-string quarterback for Miami Dolphins, a second-string, played a little bit for the Jets. He just came out on CNN the other day and said, I've been taking 1,400 tablets, opioid tablets, a month. 1,400. I don't know how much is that per day, but 1,400 per month. And he said he would do Fox TV shows, and so as a commentator, so he would get off his drugs for a day before, and then as soon as it would be 5, 4, 3, he'd hear that, he'd go to the bathroom, put in 15 tablets in his mouth, rush home, put another 15. And he talks about, he says now he's always an addict, which is kind of an interesting thing, but he says he calls himself an addict, and he says he came out to talk about how this is a big problem in the NFL. Now, there's a lot of variation statewide. We talked about Utah already being the 5th highest right now for death rates, which is buckling the trend nationwide. But if you look at the dark areas of the country, it actually is in the southeastern part of the United States. And you'll see some interesting data here. You see that in Hawaii, the chance of getting prescribed opioids is 1/3 the chance of Alabama. So it really doesn't make a lot of sense that you'd have this huge statewide variation. And this goes on. It's crazy. When you look at Tennessee, in Tennessee you have a 22-fold increased risk of getting OxyContin or oxymorphone greater than Minnesota. So why is that? And it's interesting. Northeast part of the United States, we see this long-acting greater than short-acting. CDC, what did they say? Don't use long-acting opioids. They're dangerous. That whole thing we talked about, keeping patients on opioids, long-acting, and using so they never go down, is the most dangerous thing. The less is the better. So they say use short-acting if you have to use any. The combination of opioids and benzos, again, a really deadly combination. There's really good evidence that we should just not do this. If we do this, the CDC says, use the very lowest dose. Make sure you have an absolute indication for both, and then try to talk to your patients about winding down one or both of them. So if you go to the doctor in the US, what's the chance that you're going to get an opioid for pain syndrome? What do you think? It's 20, I heard it. It's 20%, 1 in 5 chance. That 20% number keeps coming back. Remember, 20% of our soldiers coming back from Vietnam with addiction to opioids. That 20% nationwide number, where 20% of Americans have currently or in the past abused prescription-controlled medications, mostly opioids. Now, Schedule 2 is where really the big action is at, and this is where my story begins. It's kind of an interesting story. I was asked first time to be an expert for a family physician in Arizona, and the family physician was working in a rural town, small town, and she had a child, 9-year-old child of hers, patient of hers who had strep throat 5 times that year. She referred the child to ear, nose, and throat. They did a tonsillectomy, discharged the child on Tylenol codeine, which was the standard of care at the time. Now it's kind of we don't use Tylenol codeine too much with kids for obvious reasons, but at the time it was standard of care. And goes home. Mom wasn't really Mom really didn't want to give her child too much of this anyway, and her child was having such bad sore throat when he came home. He didn't really want to take the medicine, and Mom wasn't that pushy about it, so she said fine. After a while, he didn't really want to eat too much either because his throat was hurting. Mom is okay with that because he was still taking his Jell-O, still drinking. As long as he was drinking, she was happy. She she recognized how bad his sore throat must be. She tried to offer him Tylenol codeine. He didn't want to take it. Finally, he stopped drinking and eating. And drinking, and he started getting a little droopy. So mom gets a little nervous, so she gets on the phone calls the office of the surgeon, talks to the nurse. The nurse says, I'll talk to the surgeon, we'll call you back. So half an hour later, the nurse calls back and says, I talked to the surgeon, and he doesn't use anything besides Tylenol codeine. I'm sorry. But if you have a problem, he recommends that you go to the ER, and they can call him to assess your son. And he can help. Now, mom was in a rural town that was 20 minutes away from the ER. She was a single mom with 3 kids. And it was now late afternoon, and she was thinking about the timing of all this, and dinner, and all of that, and how much time she has to wait with her kids in the ER. So she decided to call her family doc. That's always helped her. Her family doctor spent 15 minutes uncompensated time. Remember, this telephone stuff is uncompensated time to talk to her about the treatment, and they came up with a plan to use a medication that would help her son. The family doctor recognized the problem may not be the Tylenol codeine was not good for her son, but at this point his throat was so sore, he wasn't going to take anything orally. So they had to come up with a plan that would bypass the oral tract. So she did. She ordered a medicine topically, called it into the pharmacy. Mom went and picked it up, put it on her child, and within couple hours, her child was doing great. By 6 hours, he was eating, drinking, and mom was blessing her heart about her wonderful family doctor that she adores, who really has helped her through this crisis. Really, it's a crisis for her. Single mom, 3 kids. So she puts her kids to bed. Next morning, she calls them for breakfast. Her 9-year-old doesn't come down. She goes upstairs to try to wake him up for breakfast. He seems to be dead asleep. He's not dead asleep. They call 911. They go to the hospital. Mom arrives when the ambulance arrives. The hospital personnel look at this child who's blue and very cold, and they know they can't do anything. But then everybody's crying, so they do ACLS for 17 minutes. They call the code. And they call the death. And so then I'm reviewing all the records. Hospital, ER records. I would probably do the same thing. Come on. If somebody came to me with a baby, I'm going to do what I can, even if it's not going to work. And then ENT note was kind of interesting. The note was only like, I don't know, 3 or 4 lines. It was really short. I was saying, is this all you write? And but at the time, Tylenol codeine was standard of care. ER, going to ER if you're not doing well, kind of sounds standard of care. So I said, nothing. What did I say to the defense attorneys for the family physician? I told them to settle. And so they did settle for $1 million, which is at the time the top of the cap. And why? Well, this child was opioid naive. And we can't use any of these drugs. We can't use any opioids in this category unless it's hospice situation in opioid naive patients, because they're just too potent. They're just too dangerous. And we'll talk a little bit more about all of them. Now, it's interesting. One of these is false. And probably, I wonder if you can guess which one is the false one here. Anybody want to guess? 4. It turns out that primary care doctors are 80%, 86% of the prescribing that leads to overdose. Now, we didn't just talk about opioids only. We're going to briefly touch on a couple things. Stimulants. If you look at this data, worldwide data, it's kind of interesting. The world prescribes more stimulants than we do. The entire world prescribes this much, and the United States prescribes this much. So one of my jobs is I take care of Olympic athletes, and we have to fill out these forms for treatment authorization requests to let our athletes take medications that are on the drug prohibited list when they go to Rio or they go to World Championships and stuff. And the Olympic team doctors in these countries are just saying no. They said no. You guys prescribe too much stimulants. It's not fair. We're going to say no to your athletes. And they're saying that. Despite a valid form, a testing that proves that they have this and they're getting benefit, they're saying no. And that partly makes sense. We have 4.6% of the world's population, but we prescribe almost as much stimulants as the rest of the world combined. Now, methadone is on the top of this list over here, while OxyContin is mostly on the top of the list in Utah, especially here in Ogden. Methadone, why methadone? Why is methadone on the top of the list for mortality? It's a tricky drug, really. It's a tricky drug. I'm not saying it's bad, and I've prescribed methadone, but I think this should be kind of experts-only stuff. Part of the reason is it's got a long half-life. So you prescribe the right dose for your patient, but the patient doesn't believe you. So they take double the dose the next day. They still don't feel much better, so they take triple the dose the next day. They still don't feel much better, they take quadruple the dose on day 4. Day 4, they're starting to feel the best effect of day 1 prescribing that you did. But they think, day 4 tablets is better than 1. And little do they know that their dose is going to continue to accumulate over the next few days, and day 7 they're going to die. So methadone is kind of a tricky one because that long half-life, it also gets absorbed in the body fat. So if you have more body fat, it can kind of cause trouble, and the effective QT prolongation. So methadone is on that list of dangerous drugs too. Here's an interesting question. You have a new patient that shows up to your office. The patient has a history of back pain and arthritis, rheumatoid arthritis, wants here for a refill of OxyContin, 80 milligrams twice a day, and Celexa. She says she's been on this for 2 years doing great. She's also on morphine ER, but she says, that doesn't work for me. I don't need that. I just need the OxyContin. That's all I need. Is that okay? How many of you say, go ahead and refill it? She's been doing fine for 2 years. Raise your hand. It's like I'm preaching to the choir. I don't need to do this presentation. And you're right, and here's the evidence for why you're right. So State of Washington looked at this in the late 90s, early 2000s. They found that they had an increase of, like nationwide, of overdose deaths and hospitalizations for opioids. So what did they do? They did a study, and they reduced the amount of opioids in the Medicaid population to 100 milligrams a day equivalent or less, and they dropped 1 year later, they dropped mortality from about 1,000 to 500 in the state. They published this data in Annals of Internal Medicine, and it's available. And why is it free even though you don't have a prescription? Well, it was co-done by the National Institute of Drug Abuse, and they paid the extra cost to Annals of Internal Medicine to allow it to be widely distributed to physicians, so you can just Google it and see it. Same thing with the VA. VA looked at this, and they found that if you use a higher dose, you have 100 milligrams a day dose, you're about 7 times greater chance of overdose and death than if you're using the smaller dose, less than 20. And so they published this in JAMA. Same thing, it's available. New York City, also similar stuff. Now, what happens when a patient overdoses? Well, the problem is, I think we just don't get the information. So here's a study that was just published in Annals of Internal Medicine this April. And what they found is over 90% of patients who survive an overdose, because this is a life-threatening condition, get prescribed the same medicine by the same doctor. And about 15 to 20% of them get another overdose again. And why does this happen? Either the doctors don't believe it, or we're not sharing information from the hospital to the doctor's office. I'm not exactly sure, but this is an important point that we need to find. If someone has had an MI, they're at high risk of an MI. Someone has an overdose, they're at high risk of another overdose. We need to know about that and act accordingly. Now, these drugs are so confusing, really. And that's part of the problem. There's too many of them. There's too many names. These names get us all confused. The dosing is very different. And it's not exact science. So there's a little variability. For example, methadone is fat stored, so that it goes up in potency as you have more fat. So 15 milligrams chronically could be equivalent to 100 milligrams of morphine. So it's really interesting when you think about this. Oxycodone is kind of variable how much potency it is. It's either double or a little bit less than double the strength of morphine. Oxymorphone is very high. So it's hard going back and forth between these medications. Now, one medicine we should stop prescribing is fentanyl. We talked about this already. Fentanyl is good if you're in terminal cases or you're in the OR. But fentanyl is not good for home, especially the patch. And why? There's such a variable penetrance of a drug through the skin. So if you have a drug that has a variable range between 60 and 120, or 130, which is 25 micrograms, that's going through the death zone. It's like Everest. When you hit like 26,000 feet, that's the death zone. You can't sleep above that zone. You're not going to make it. And so this is that death zone. The CDC says the death zone is now 90. They set the death zone at 90. They want us to stay under 90. So fentanyl patch, by definition, goes over that in some patients, so we should not use it. Now, the reason we shouldn't use it is, how many times would you, if you had a drug like an ACE inhibitor, but it had, for one dose, it was like 10 milligrams was equivalent to 20 or 30, I mean, you wouldn't use it because it's too variable. So you wouldn't use a topical ACE inhibitor. Another thing interesting, if you ever see someone with a fentanyl patch on the scrotum, well, you know what to do. Okay, so what about in the ER for MI? So it's interesting. This is not cause and effect data, but it's interesting data. The Crusade study showed patients who got morphine for chest pain had a higher mortality. So we have some controversy at UCSD whether we should use morphine for chest pain. Some of the cardiologists are doing it and some are not. But I could tell you that the editor-in-chief of JACC believes this data and refuses to let any of his fellows use morphine for chest pain in the ER because of the increased mortality that we see in this case control data. Now, Schedule 3 drugs, which one of these is not a Schedule 3 drug? Which one's not a Schedule 3? A is right. So codeine is not Schedule 3. So talcodeine is Schedule 3. Imparin codeine is Schedule 3. Why codeine is not Schedule 3? Well, you know, on the street, it is well known that if you take too much talcodeine, you're going to end up in the ER needing N-acetylcysteine, right? You're not going to make it. You can only take so many tablets before you're Dundee. And so codeine, well, you can take a lot if you have a tolerance for it. So that's why codeine is, I think, stuck in the Schedule 2. Now, all these others are Schedule 3, including Special K. What is that? Ketamine. That's ketamine. Now, Special K, I mean, it's crazy when you think about it. We have 3 names you have to know. You have to know the generic name, you have to know the brand name, and you have to know sometimes these street names. The more street names the drug has, the badder it is. Okay, so why anabolic steroids are scheduled? Well, many Americans misuse these. Now, if you are a doctor and you're misprescribing anabolic steroids, who is going to be coming after you? Who potentially is coming after you? Is anybody coming after you for misprescribing anabolic steroids, overprescribing it for not really the best reasons? A fellow by the name of Roger Goodell might come after you. Now, why would Roger Goodell come after you? Who is Roger Goodell? Commissioner of the NFL. So he really doesn't like overprescribing anabolic steroids. And I can understand, you know, I was on a government oversight committee with the late Bill Walsh, and he told me in the days in the 80s when steroids became popular, he would have 3 social workers go to the courthouses and bail out his players on Friday nights so they could play for the 49ers on Sunday because they were beating up their wives. So and this was a scourge in the NFL for a long time, and Goodell has been trying to get it out. And in this process, he's actually put some physicians in jail, including one of the former head team physicians for the Baltimore Ravens. So he is very much on one page for this. Now, some of you guys know about this advisory committee meeting that happened in 2012, where they basically said, look, Tylenol has some risks too. And so we have to keep track of the Tylenol. And one way to keep it down is to reduce the dose of Tylenol in the combination medications. They also said we should stop using combination medication. They actually, the advisory committee voted, majority said we should stop combination medication, which would be interesting because 99% of the world's Vicodin is prescribed in the United States. 99%. So it's interesting when you think about the combination use. Now, urine drug screens, urine tox tests. This is a little tricky. Nationwide, the clinical practice guidelines are recommending this for everybody on controlled medications. The CDC is now recommending this for everybody. They recommend it the very first time you prescribe it and at least annually. That's in their newest guidelines. But it's a little tricky, as you know. This can be false positive. There can be some false negatives, and sometimes it's a little tricky. When you get it, though, if you do get it, and there's no drug that you prescribe in there, and it's in the urine drug screen, what do you do? And the urine drug screen comes out negative, even though you're prescribing a medication. What do you do? Too many doctors just ignore this, thinking, well, negative is no big deal. The problem is Federation of State Medical Boards, they don't think this is no big deal. Because as we talked about, this is a problem that vastly goes beyond the individual doctor-patient. This is a nationwide epidemic. These drugs are getting out there and getting who knows where. Now, it could be a false positive. The patient may not be taking it recently, so you may have to repeat it, document it. But you have to document something in your medical record to explain why you're doing what you're doing. False false positives too. That was false negatives. False positives is a problem as well. So if you get a positive of cocaine and methamphetamine, that usually for most people, or heroin, that usually for most people is a done, one time done, no more. Methamphetamine, cocaine, heroin, one time done, no more controlled medications for this patient, at least unless you have an addiction specialist that says they're safe. Now, other drugs, like say they're doctor shopping, doctors have some choices here. If they're going to another doctor's prescribing a controlled medication for them and they didn't tell them, you can make a decision to continue prescribing or not, but you've got to document in your medical record, and it's got to sound reasonable and prudent. That's all it's got to be. Okay, so what do we have data about efficacy of these drugs? Do these opioids that we've been prescribing, do they actually work? Here's a study funded by the National Institute of Health and done from Oregon Health Sciences that was just published in 2015. We don't have a lot of data. As you see, there's 4,000 articles that they looked through in the systemic review, and they ended up coming up with only like 40 that were useful after they reviewed all this. What they found in those 40 is they found 0 that showed any benefit for pain relief after 3 months. They found 19 that showed harms, all kinds of harms, including increased MI, increased fractures, kind of interesting harms, falls, of course overdose. They found not much data on dosing and strategies with dosing, and they didn't really find great data with those tests that we do, like the tests that we give patients to see if they have a risk for addiction, the opioid test scores. So overall, this is a problematic study. The systemic review doesn't really answer all questions. Just because there wasn't any data showing benefit doesn't mean no benefit exists. But it's the first step in trying to understand, do these drugs actually help long term? We do know, as you can see from this graph, there's a lot of problems. Fractures, myocardial infarction, 40% increased myocardial infarction in patients taking opioids. Sexual dysfunction, testosterone goes down. That's a great way to get people off drugs. Oh, this is going to affect your testosterone. Your libido is going to go down, which is true if you take this long enough. Fractures, falls, abuse, and overdose. We know this. We don't know function improvement, pain improvement. We just don't know. There was no data that showed any of these. So Ultram, some of you guys, I used to over-prescribe this too, and I've cut back recently. When the FDA got the data from the company in 1995, the company purposely didn't allow anybody with addiction to come into their studies. So they weeded them out. They made, research studies, pharmaceutical companies, they really choose their patients very carefully. They have a very rigid process, and they have good follow-up with those patients. So in their data, it looked very safe. So the FDA decided, let's not make it controlled. However, look at this, 16,000 ER visits for non-medical use of tramadol or Ultram in 2010, 3.2 million people in the US non-medical use lifetime, 9 deaths 2012. Now, all those deaths were former addicts who they just overdid it, took too much. So now this drug has now been reclassified as a Schedule 4. Now, patients, when they die, they don't just die of one drug. Only about a third of the time they die of just the one drug. It's often mixed with a little bit of alcohol or benzos or street drugs. It's a combination, and so that's the reality. Now, one of these should not be a Schedule 4 drug. Which one should not be Schedule 4? They're all Schedule 4, but one shouldn't be. I have a picture up there. So I'm coming home one day from LA to San Diego on the train, and I'm sitting next to a young woman who's studying law at a college in San Diego, University of San Diego. And she's missing one of her legs, and after part of the journey, I asked her, I said, well, what happened? And she kind of turns to me, sighs her head, and she said, my friends and I went clubbing together in Los Angeles, and they noticed this weird guy next to me, and so they grabbed me and they took me away, and we drove back home on the freeway. On the way back on the freeway, while we were driving, I got a little confused and I stepped out of the car. 23 operations. She survived but lost her leg. all of the bars in the United States, most of them, and many, many public places are being videotaped by closed caption television, CCTV. It's everywhere around us. This bar had a CCTV video where they could see the guy actually putting a tablet into her drink. Now, why didn't she notice this? Number one, she wasn't right there. Number two, her drink was opaque. Number three, the bar was so dark, and he had a cap on, you couldn't see anything there. Now, the companies who've made this drug, flunitrazepam, which is better known as Rohypnol or Roofies in the slang term, they've tried to make this drug tamper-proof by putting a blue dye, so when it goes into a drink, if you put it in your water, it'll make the water blue. However, come on. It's just not enough. This drug is mostly used for nefarious reasons. We should get out of the business of this drug altogether, and it should be a Schedule 1. Many states have recognized this. Now, if you're in a hospital or a state where it has a rule that's stronger than the federal rule, which rule should you follow? If you're in Florida and they say this is a Schedule 1, can you prescribe it? No, no, no. You follow the most conservative rule. If it's your hospital, if it's your group, if it's your state, or if it's the feds, you follow the most conservative rule of all those rules, all the time. That's the way you do it. And so in Florida, Idaho, Oklahoma, you just do not prescribe this drug. In fact, it shouldn't be prescribed anywhere. Maybe it'll be one of these new things. Now, 6 to 10% of Americans take sleep aids. These drugs are everywhere. We prescribe them a lot in America, and for a long time we've thought they're pretty benign. Not true. So here's a study. This is a case cohort study, so it's done by the leadership, the editors of the Women's Health Study. The people who ran the Women's Health Study ran this study. It's not a perfect study, though. There's some limitations, but it's interesting data. If you look at this study, they looked at 10,000 patients in San Diego who were going to Scripps Clinic, who were getting sleep aids, all different ones. Benzos, Ambien, all different ones. Average age or mean age was about 53. Then they looked at 25,000 controls, similar age, sex, risk factor for MI, cancer, accident, etc. And they followed them for 2.5 years. It was a prospective case cohort study. What they found is if you took as little as 4 to 18 of these tablets a year, your overall mortality was 3.5-fold greater. If you took 18 to 132 was 4.5. If you took it almost every day, it was 5.5-fold greater. 11% of the patients prescribed Ambien in that 2.5-year study had died. Average age was 53 in 2.5-year study. So why are they dying? It looked crazy on the map. Everything was increased. Even cancer mortality was increased. You cannot make a cause and effect relationship. This is not a randomized controlled trial. British Medical Journal, though, says if the editors felt that odds ratios over 3, that's a signal. When you see an odds ratio of 4 or 5, that's really serious. You know, odds ratio 1.5 in a case cohort study could be just total chance. But this is really bigger numbers than they had expected. So the British Medical Journal said, we're just going to make this free for everybody. We're just going to make this open. So you can go plug in Ambien Death, go take a look at this article yourself. It's a limited article. It's got a lot of problems. This is a case cohort study. It's not a randomized controlled trial, but it's very interesting. It makes us think. When you look at UpToDate, what do they say? The best way to treat insomnia. They talk about sleep hygiene. They don't talk about drugs. And this may be more reason. Now, Schedule 5, is there any risk for this? Who is this fellow? Who is this fellow? This is Jamarcus Russell. Now, some of you may know Jamarcus Russell. He's a quarterback from LSU who's the #1 draft pick for the Oakland Raiders. And he had a specialty. What was his specialty? His specialty was throwing interceptions. He was really good at throwing interceptions. Touchdowns, that was another thing, but interceptions for some reason. Now in LSU, all he did is throw touchdowns. In NFL, all he does is throw interceptions. What happened to Jamarcus? Well, I'll tell you what happens, because I grade the San Diego Chargers, so I do physicals on the San Diego Chargers, so I know how it works. We give them 2 grades, a medical grade and a orthopedic grade. I give the medical grade and my orthopedic colleagues give an orthopedic grade. The grade counts for money. So he was injured coming into the combine, but didn't tell anybody except his fellows at the combine, 240 or so other football players, who said, well, take this. And he started taking this, which is the purple drink. It became big in the hip-hop world of Texas, so it's called the purple drink. Why purple? Well, you know, companies that manufacture Finnegan and codeine to make it more palatable for the kids and stuff, or adults, they put a little dye in there. It tastes so bad you can't drink this regularly. Come on, you have to mix it with some soft drinks or Jolly Rancher candy, and the purple hue comes from this dye. So he was using this from the combine, and he used it every day, including days he played football. So before the games, that's why he became a specialist in the interception and not so good in the touchdown. And so eventually he got dropped by the Raiders, and he ended up getting caught trafficking. They called it trafficking because he had such a large supply of these drugs at his house. They called it trafficking, and he ended up getting community service and told his story about how this started and how it's so dangerous for players to tell their real injuries because they're worried about not getting their contracts. Now, Texas also took a lead in another area. One of them was this refill thing. So Schedule II drugs, one of the problems for all of us is you can't make refills. Now, why is that? Well, in 1972, the Senate and the Congress and the White House felt that these drugs were so dangerous, so risky, that they didn't want doctors to refill them. They didn't. They want to make it hard. If you have to refill, you have to write a new prescription. And they made that on purpose. So Texas created this little thing where they said, for 90 days, let's allow doctors to write multiple prescriptions, date them on the same date they see the patient that day. Every single one has May 18th or May 19th on it. And then you can say, do not fill until a certain day. So they created this model, and it actually worked. So patients would show up to the pharmacy with 3 or 4, 10. 10 would be cool because then you really gate it. So if you think they're diverting and they have to go back every 10 days or every 7 days, it's not worth it for them. They're not going to want to do that anymore. So whatever, 3 of these, they rewrite it, and they take it, they hand it to the pharmacist. The pharmacist can store it or give it back to the patient. They can bring it back, and then at the appointed time, they come back with that same prescription, and so you can get 90 days for your patients with Schedule IIs. You know what? The government thought this was a good idea, and Congress allowed this in 2007, and now you can do the same thing if you want to for your patients. You have to date it on the day you prescribe it. Here's another case. Here's a woman that you've been taking care of, young girl, who she has been going to your local urgent care folks for a while. And she keeps popping in for some refills of the medications you've been prescribing, and your colleagues are getting mad. They're kind of getting mad at you because she's a frequent flyer over there in the ER urgent care, and they're giving her 3 days, 7 days, but they're tired of this. And so one day they call her out, they do a urine drug screen, they find out she's got other things in there. They call her for what it is, addiction. She admits it, and then they do the right thing. They get her into an addiction medicine group, and she's going to get scheduled to have an appointment in 7 days. They don't prescribe any more medications. She calls you and says, look, doc, I have run out of my medications. I've used them all. I'm going to go into addiction. I have an addiction problem. I'm going to go addiction. I'm going to go addiction next week. I'm a Suboxone program. Can you just give me the same Vicodin you were giving me from today till then, the same amount for my back problem that you've been always giving me, just to bridge me till I get to this addiction specialty clinic? Who says you can just do this? You've been doing this for years already, and it's a safe dose. She hasn't had any problems. A low dose. Can you do this? Raise your hand if you think you can. You cannot. You cannot. And why can't you? Well, now we're going back in time. Back way in time. Now, back in time is interesting. I went to the Coke factory in Atlanta, and you always wonder, what's the secret ingredient in Coca-Cola, right? What's the secret ingredient? You go to the factory, and you can see the museum, you look around, and in the cabinet, in the Coke factory, I looked carefully, and I didn't find cocaine. I found codeine in the cabinet there. So I wonder, could that have been the secret ingredient way back? Who knows? I can't say for sure, but that's a picture of way back. Now, way back in 1914, Harrison had passed a law that basically said, Senator Harrison, that doctors can only prescribe opioids in their practice, which the police and the DEA and all these people do not believe taking care of people with withdrawal and addiction is part of the practice, except if you're in a jail or you have a special DEA license to do this, like the Suboxone, methadone, or you have a serious injury or accident. So this girl had a new accident or injury, so she's basically now just needs opioids for withdrawal, and you're not allowed to do that. Just not allowed. So you can't give her the medication. This is another one that's kind of tricky. Which data is not necessary? Everybody would say allergies, checking allergy history is necessary, but reality is not necessary. The pathology of purpose is necessary. Where do we miss this? Where is the time where we miss putting down the pathology purpose of our prescription? It's on the phone. It's when we take a phone call and we refill a medication, we don't write the diagnosis on the prescription oftentimes, and we don't make a note, and now we failed this fundamental tenet of law, federal law, that we have to do every single time. What about family members? Can you prescribe controlled medications to your family? Yes or no? I hear interesting voices here, different voices, and I can totally understand. Let's talk about this. So here's a story of one of our doctors in San Diego who's chief of staff of a local hospital of 1,000 doctors. He was a neurologist and professor at the medical school, and his wife died. And when she died, she was known to die of an overdose, accidental overdose of controlled medications. Well, this is a known problem. The problem happened to be that on the prescription bottle was her husband's name. So the police had to deal with this because there was a coroner that made this report. So they went to the hospital and they asked the nurses and staff, is this doctor legit or is he a criminal? Basically, they're trying to figure out, did he murder his wife? And everybody said, no, we love this doctor. He's great. We love him. And they said, well, they're not 100% sure. So they went to the his wife's family, and they interviewed them and said, what was their relationship like? Was he abusing her? There's anything nefarious? They said, no, they had a loving relationship. He always took good care of her. No, no, no. So then they said, yeah, we dropped this case. And they said, well, we just administrative solution. What does that mean? Medical Board of California. So he goes to Medical Board of California, and they ask him about this. And then they say, well, can you tell us, show us your medical notes. So then he started writing. And they looked at him, and they're wondering, what is he writing? And they said, well, what are you writing? And 5 minutes later, they said, oh, I'm writing the medical notes. And they said, oh, thank you so much, Dr. JG. We're very pleased to have had this interview with you. We'll call you and tell you what the results of it are. What happened to poor Dr. JG? He didn't lose his license. He put on probation for lack of medical records. So there is actually no federal prohibition to prescribing to family members. However, I have to tell you, it's not a good idea. Many hospital and medical groups around the country will say, don't do this. And so if you are in one of those groups, you're lucky, because there's too much of a risk with your family member. It's too hard to be unbiased. So just don't do it. It's not against the law, but I would just skip it. I'm going to skip this because we're kind of short on time. Internet prescribing, is it legal? Your online source for Proscar, Propecia, Cipro, Viagra, Xenical. Any of these controlled? No, none of these are controlled medications. So can you do this, yes or no? Yes, you can do this, or no, you can. Who says yes? Who says no? Kind of some not sure. Okay, let's answer this question with some new story. So the feds say this. This is from the DA website, by the way, which has a person on the website in jail, which is not a good sign. And then they say, federal law requires that prescription for controlled drugs to be effective must be issued for a legitimate medical purpose by an individual practitioner acting in the usual course of his professional practice. His patient has to have a medical complaint. The medical history has been taken, which you can do online, by the way. A physical exam has been performed, and some logical connection exists between the medical history and the physical, etc. So, if you are doing internet prescribing, can you prescribe controlled medications? No, you can't, because you're never going to be able to do a physical on the computer. So even telemedicine is just not going to work for this. So you're going to be in trouble here. Another problem that's interesting about this is the connection. If you see a patient who has back pain, can you give OxyContin and yet click off the button that says their back exam is normal? No, you can't do that. You've got to have a logical connection between the history, the physical exam, and the treatment. It's got to all make sense. So here's a last little story I'm going to tell you before we take a break. Ryan Haidt bill is one of the more recent acts of the Senate and Congress and updates the Controlled Substance Act. And what this basically said, Coleman and Feinstein bill said, you cannot prescribe anything, controlled or not controlled, over the internet. Now why? Who is this kid Ryan Haidt? Well, Ryan was a junior high school star tennis player in San Diego. And he ordered Vicodin online. Mom trusted her son. He's an honor student, wanted to go to medical school, great kid. So the box came for her son from the mail, and she just handed it to her son without opening it. Inside that box was Vicodin. And Ryan didn't know how to take the Vicodin, took too much of the Vicodin, overdosed. One day she calls him down for breakfast, and he is dead in his room. And Mom traced back this online purchase. So this was passed unanimously by the Senate and Congress. So in no circumstances can we prescribe controlled medications or not controlled medications through the internet. We're going to skip this because I want to finish here. And I'm going to just answer a couple little questions. And this is part 2 tomorrow. So any questions? Thank you.
What advice do you have about covering physicians or your physicians out of town and you're left in the office and you have requests for some of their chronic pain patients?
Good. So it's a great question. I had a slide. I passed it. It's in your slide deck. So it talks about this. So I've had advice. So there's a law that allows 72 hours of prescription for a patient you've not done a good faith physical exam on. Also 1 month in a nursing home. The law specifically says you cannot increase the dose, strength, and amount without seeing the patient. What about for a patient that you have a chart on, a patient of your practice that has been coming to your practice, has had a good faith physical exam from one of your colleagues? Well, my advice to physicians has been routinely, I think it's okay to give them a 1 month supply, no refills, just a 1 month supply, don't increase it. And then I contacted the Medical Board of California just to see if their attorneys would agree with this, and they said in general the advice you're giving is correct. They sent me a letter back, which is should be in your file, and they said in general the advice you're giving is correct, but patients still have to be, doctors have to be prudent and reasonable here with that 1 month. So if you have a chart, now if you don't have a chart, if you're just cross-covering, you don't have a chart, follow the 72-hour rule.
Question about methadone clinics. We have some of those in Utah. It seems that some of their laws are different. They dispense their medications directly from their facility rather than using a separate pharmacy, and it doesn't show up on a Doppel report. And I don't think they necessarily see a doctor every time. So can you speak to that, methadone clinics?
Yeah, so I think patients who have an addiction, these are special patients. We shouldn't be prescribing controlled opioids for them or controlled drugs in general. Don't prescribe benzos. You don't know what dose they're getting of the methadone. They don't even know. It's a dose that's coming slowly, little by little, so we shouldn't compound it. Now, in a serious emergency, an accident or injury, you can, but these are really delicate situations and you have to be really careful because the risk of overdose is high. And you're right, they do not get put in the drug databases around the country. So we won't be able, you can't check on them like you can other patients.
As I have a comment just and a question. I worked for the VA hospital system about 5 years ago, and I probably wrote more narcotic prescriptions, opioids, in that 1 year than I had for 30 years in private practice. And I just wondered, is the VA looking at this? Because we got a lot of pressure from on high. They didn't want any complaints from the vets, and they don't want you to spend any time. And it takes 30 seconds to write a prescription for an opioid and send them on their way. And I've written like 150 for a month, and then I see them walk out the building and share it with their friends. And we report that to administration, and they don't do anything about it at that time. And I just thought in the state of Utah, especially where I work, one of the source of prescription drugs is our dear VA hospital. Is supposed to be a medical center and a good example, but they were sure setting a bad example as far as I could see.
Yeah, you're unfortunately totally right. For a long time, the VA was a big source of the problem for themselves. Like I showed the data that 35% of soldiers who had PTSD and a substance abuse history were getting opioids, which is astounding data. And so the VA did this study that's published in JAMA. You can read that, where they found the higher mortality amongst the higher dose, over 100 versus the low dose. I think the struggle at the VA and nationwide is the shortage of doctors. And so sometimes it's easier to write a prescription than to spend time and find a solution for patients. And that.
What they say, if you quit or you do it, I had an MPA that actually got charged for overdosing and then everybody backs up as soon as somebody puts that.
Yeah.
And I just left.
Yeah, I totally agree. That's why I showed the Doc Bader video too about the customer satisfaction thing. We should divorce patient satisfaction from prescribing because there's too much of a risk there. All right, I'm going to step down. I'm going to be back because we have part 2 coming up tomorrow, but I think we have another speaker right now.